Hopefully, you had a chance to check out today's case. Basically, you were sent to a local apartment building for a male patient with weakness. Upon arrival, you met John. John is a 64-year-old male who states he's having difficulty moving his legs. It's to the point where he can't really even get out of bed. So he states the weakness began around 3 to 4 days ago, but he's been kind of progressing to this point, being much worse today. He states he can feel his legs, so he has sensation, but that they keep cramping and that he can't move them or really walk. He also complains of anxiety, fatigue, and dysuria. In regards to his dysuria, he states, it feels like there's something in there, but I can't force it out. He denies recent illness, fevers, etc., and he denies any trauma, falls, back injuries, neck pain, back pain, etc. So, John has a history of COPD, asthma, hypertension, GERD, and prior MI with one stent. He takes albuterol, Spiriva, omeprazole, hydrochlorothiazide, famotidine, fluoxetine, aspirin, and lorazepam. So your partner gets some vitals for you, and they're relatively unremarkable. He's got a heart rate of 86, a blood pressure of 140 over 80, a respiratory rate of 16, SpO2 is 96% en room air. He's got a temp of 37.1 Celsius or 98.7 Fahrenheit, and then a glucose of 120 milligrams per deciliter or 6.7 millimoles per liter. So all pretty unremarkable. So, really, what are some differential diagnoses for weakness? Because it's a really broad complaint and the list is really expansive. So, there's a lot of different causes for weakness, things like strokes, spinal cord issues, shock, infections, polio, toxins, glucose issues, Guillain-Barré, electrolyte issues, myopathies. There's a lot. Now, for me, weakness is either neuromuscular problem or something else, right? And I kind of break it down into those two categories. And those are how I like to think about the patients. So, is there a neuromuscular problem causing this weakness? Something like way above my pay grade, usually, or is there something like a stroke or an electrolyte abnormality or a shock state that's causing the weakness? The later cases, the non-neuromuscular causes, are actually by far the most prevalent causes of kind of the objective complaint of weakness. However, other things need to be ruled in or out also. So, what is weakness? Because weakness as a complaint is really vague, and patients tend to use the term a lot to describe fatigue or malaise. So it could really be anything. Weakness is the reduced strength in one or more muscles. Fatigue is exhaustion, weariness, kind of tiredness, and malaise is that general feeling of discomfort or illness. Just kind of to suss those out. But patients often just call all of those things, I feel weak. So I assess it as if there's something wrong with the brain or spinal cord first, as if it's like a true neuro problem. And then I prove to myself that it's not. So let's assess John here. So assessment, like with any other call, starts with the ABCs. So we need to rule out life threats before anything else. And this is, if this is a true neurogenic cause of weakness, you need to be careful about the airway and breathing. So look for things like poor mentation, difficulty with speech, drooling, the inability to lift their head, their mental status in general, and really any other red flags for standard respiratory issues like weak, shallow breathing, tachypnea, etc. There are a lot of neuromuscular issues like Guillain-Barré, for example, that present with lower extremity weakness that can rapidly progress to have a diaphragmatic involvement. So these patients can go to respiratory failure. So for John, his airway and breathing are both fine. He's speaking in full sentences without shortness of breath, no difficulty breathing. He's managing his airway well. He's controlling his head, his neck properly. All of that's fine. And all in all, AB, he checks out. And really C2, he's got a normal heart rate, good blood pressure, normal skin signs, good cap refill, etc. So really his ABCs are fine. His were checked within about 30 seconds, right? Because like you're just kind of approach, you can look at all of these things for the most part. And then I just moved kind of right into history taking. So history taking is really important in weakness. It's a good history is an art form, and it can't really be understated here. And for the sake of time, I'm going to go through every question I would I'm not going to go through every question I would ask, but here's kind of the important parts from its history. So the weakness came on progressively a few days ago and is worse today. It's mostly in his legs. However, he admits it's been, generally weak all over for the last few days. There's this associated intermittent leg cramping as well, and he's been anxious about all of it. He describes feeling kind of tired, run down. He has been dieting, so he's not been eating or drinking, or he's been eating and drinking, less recently. He's on hydrochlorothiazide, which is a thiazide diuretic, which is always important for a weakness complaint, and kind of more on that later. He takes 25 milligrams twice a day for a total of 50 milligrams, or at least he's supposed to be. Turns out he's been sneaking an extra one here and there because his blood pressure's been increasing over the last couple months. He's just been kind of checking it with one of those little like home cuffs. So he's kind of been self-treating that because due to a viral infection over a month ago, his PCP or his primary care doctor um, canceled his appointment. So he's just kind of been winging it for a bit. So he denies any incontinence, but endorses dysuria and basically states it feels like there's something in there, but that he can't force it out. So he's got like this urinary retention. So he's making urine. He just seems like he can't pee. He denies fevers, chills, falls, trauma, abdominal complaints, chest pain, unilateral weakness, dizziness, lightheadedness, and kind of just other feelings of near syncope. And here's where I would like to move kind of onto his neuro exam, right? So now we don't need to check off every box like a neurologist does, but some basic questions we want to answer, right? For one, how are they mentating? John's mentating fine here. He's CO times four. He's answering all of his questions appropriately. He's got a relatively clear voice without appreciated cloudiness or confusion, things like that. And then we would move on to a brief cranial nerve exam. And I'm not going to go down that whole rabbit hole here. There's lots of great videos on neuro exams, and there's textbooks and stuff like that. And I highly recommend you look those up because a neuro exam is important and a cranial nerve exam is important. And you should probably know what most of these mean at the paramedic level. Generally, what we do is we test cranial nerves 2 through 12, and we'll just say his exam was unremarkable. They were all intact. So moving on from there, we go to motor exams, and here we're looking for tics, tremors, pronator drift, muscle tone, function, strength, and there's a specific way you're actually supposed to grade muscle strength, and it's based on a 1 in 5 scale. His upper extremities were 5 on 5. His lowers, on the other hand, were not. So both legs were just 3 on 5. So basically, he could move them against gravity. But as soon as I added like even the slightest bit of resistance to his movement, he couldn't move it at all. So no wonder why he couldn't stand. And this is what he meant by saying that he could barely move them. They weren't paralyzed, but functionally, he couldn't use them. He couldn't get out of bed. So he has sensation bilaterally, and that seems perfectly intact. He's just got that 3 on 5 weakness in the lower extremities. So John has bilateral, isolated, proximal lower extremity weakness. Proximal just meaning major function wise, right? So like he can't lift his leg from like the thigh part, not the small parts of his foot. It's more proximal. So he's got bilateral isolated proximal lower extremity weakness. And to me, I'm not a neurologist by any means, but this exam was odd, right? He didn't seem super neuro to me at this point. It seemed more like a myopathy or basically muscle related, not nerve, spinal cord, brain, etc. So, what can cause myopathies? And really a whole bunch of stuff, but the big ones are inflammation, things like rhabdomyolysis, medication side effects, toxins, and pressingly, electrolyte abnormalities. So, with all of that, what is your working diagnosis? What do you think is going on here? Pause the video, take a guess before I kind of lead you down the road I went. And because for me, this screamed electrolyte abnormality, and specifically hypokalemia and or hypomagnesemia. And to be fair, they happen together most of the time. And then here's just kind of how I put that together, right? So for one, he had this proximal weakness of the lower extremities that progressed up. And that just screams myopathy to me. And electrolytes can be a big cause of that. And then a big thing that needs to kind of be thought is that there's also Guillain-Barré's, um, as it also tends to start low and work its way progressively up, but it usually starts as a more distal problem. And there were a lot of other kind of red flags that made me less concerned about it. So always keep that on a differential when it comes to like isolated weaknesses somewhere. But The weakness came on progressively, not suddenly, and that kind of rules out a fair amount of differentials to me. And then there's this weird leg cramping, and I don't know if we all played sports or anything like that, but if you did, you know that that tends to be like a dehydration electrolyte issue. He's been generally tired. He's been dieting, so he's eating less than usual, aka bringing in less electrolytes. And he's also on hydrochlorothiazide, which is a thiazide diuretic known for causing hypokalemia. And he's been taking more than prescribed in kind of this form of self-treating his worsening hypertension. So now we have a decreased intake and an increased outflow of potassium. So, kind of putting that all together, hypokalemia kind of became my primary differential there. So, we don't have labs on the ambulance, but we do have something else that can be helpful here to kind of support this diagnosis. That's an ECG machine, right? And just like just like the more popular and well-known hyperkalemia, hypokalemia has typical and well-documented ECG abnormalities too. And around 70% of severe hypokalemic patients present with these traditional ECG abnormalities, or at least one of them. And the big ones are flattening T waves, which is usually the first sign, and then you get this progression to absent T waves, T wave inversion, and ST depressions. You get a prolonged QT, and then something called a U wave, you know, can be seen as well, which is this positive deflection after the T wave, basically. Now, this isn't his ECG, it's a representative one, but it was similar to his. So, what do we have here? And basically, you got a sinus rhythm, you have these prominent U waves, particularly in the precordial leads, and then you got this QT prolongation and then some ST depressions. So to me, this clenched the diagnosis, right? He's hypokalemic and he's suffering from something called hypokalemic non-periodic paralysis, um, which was precipitated by a thiazide diuretic and then complicated by poor PO intake. So let's kind of talk about that. So first, just kind of a brief overview of potassium. So the normal range is 3.5 to 5. Usually, it depends on your lab, and it's mostly regulated by the kidneys and a little bit by the GI tract. 'Cause that's how we get it in. It's also heavily influenced by both insulin and the pH. So potassium is the major intracellular cation, which means it's positive. 98% of it lives inside the cells, whereas only that 2% is actually what floats around outside of them. So it's sort of or at least how I like to think of it, is the opposite cation to sodium, which lives mostly outside the cells with only a little bit inside the cells. And the ratio of sodium concentration inside versus outside the cell is actually the strongest influence behind cell membrane polarization. So, potassium's main role in the body is to maintain the resting membrane potential of cells and to facilitate electrical impulses. So, it's mostly what keeps our cells more, relatively negative. It does other stuff too, but this is kind of the big thing that's important for today. So, now let's talk about hypokalemia. Hypokalemia is defined as a potassium of less than 3.5. And this is actually really common. It's probably the most common inpatient electrolyte abnormality. And generally speaking, patients tend to be asymptomatic until they're really severely hypokalemic. And severe hypokalemia is defined as a potassium less than 2.5. And then that's usually when symptoms start, right around then. And they can appear sooner. It's just usually they don't present much until severe hypokalemia. So there can be several clinical manifestations of hypokalemia, including kind of all of the following, right? You have hypertension, orthostatic hypotension, arrhythmias, malaise, weakness, fatigue, hyporeflexia, cramps, paresthesias, paralysis, rhabdomyolysis, nausea, vomiting, abdominal pain, etc. The ones we tend to care about, kind of acutely, are these, and these are the ones that we tend to see: arrhythmias, weakness, and paralysis. The muscle weakness being the most common symptom, right? This weakness is usually ascending, which means it begins distally in the extremities and then kind of progresses up. The big jams, like death-wise, come from arrhythmia and then from respiratory muscle paralysis or fatigue. And these result from issues with membrane polarization, which disproportionately affects the heart and the neuromuscular systems. So potassium maintains the resting membrane potential. So when potassium is too low, the resting membrane potential becomes more negative, which means it's harder to initiate a new action potential. So the cell is less excitable. And this is the primary mechanism of the problems in both the heart and the muscles. And this is what results in the weird ECG changes that we see with the flattening T waves, ST depression, prolonged QT, which can lead to torsades and the U waves and stuff like that. And always keep in mind, hypokalemia is closely associated with hypomagnesemia as well. So the two usually coexist. Magnesium is important for this sodium potassium pump activity, especially within the kidneys. So in the setting of hypomagnesemia, more potassium is excreted. The two are very closely linked. And the diagnosis of hypokalemia is based on lab results. It's something called a basic metabolic panel or a BMP, and this will give you the value. It'll give you a serum potassium. And that's clinically correlated with the ECG and the clinical manifestations that you can see. And as we already discussed, John has multiple signs and symptoms associated with hypokalemia and a relevant ECG as well. So I mentioned before that hydrochlorothiazide is known to cause hypokalemia, which is true. Um, really, almost all diuretics, with the exception of the potassium-sparing ones, which is actually like a separate category of diuretic. The main one being spironolactone is a potassium-sparing diuretic. You'll probably see that one a fair amount. So, you know, the rest of them all cause hypokalemia. So if they're on a diuretic, they're at risk for hypokalemia. But what are some other causes? Really, there's three kind of main mechanisms with hypokalemia. There's either not enough intake, there's too much output, or there's this intracellular shifting that takes place. So, not enough intake, the patient, hasn't had enough intake, right? We get almost all of our potassium through our food and we eat or the beverages that we drink. And if we don't eat or drink enough, in like cases of anorexia, acute illness, or even like alcoholism and the like, we don't bring in enough potassium. And this can obviously lead to there not being enough floating around. When we talk about output, we think of things like GI loss, renal loss, dialysis, sweating, stuff like that. The big ones tend to be diuretics and diarrhea. And this is where that whole diuretic thing comes from, too, right? Because diuretics are a major cause of potassium loss. So there's too much output. And then finally, the shifting. So drugs like beta adrenergics, so like albuterol, insulin, those types of things shift potassium intracellularly. And then alkalosis can do this as well, and so can like hypothermia and stuff like that. There's also this condition called hypokalemic periodic paralysis that does this as well, but this is kind of a rare thing, has a genetic component. Is caused by different triggers in specific patient populations beyond the scope of today. So let's get back to John. John's been dieting and therefore probably has some degree of poor intake. And more importantly, John is on hydrochlorothiazide and to top it all off, has been taking too much of it for a bit. So let's talk about thiazide and kind of diuretics more broadly for a second. So, diuretics affect the kidney, and more specifically, they affect different areas of the nephron, which is the functional unit of the kidney, to increase the kidney's urine output. And they're generally prescribed to treat things like hypertension or, to decrease edema. Nephrons, being the functional unit, here the blood is filtered and kind of the fluids and electrolytes are balanced out. Some is retained, and then the rest is gotten rid of in the urine. So, what happens is filtrate leaves the blood and enters the nephron at the glomerulus. And then it travels through the proximal convoluted tubule. Down the loop of Henle, there's a descending limb and an ascending limb, and that dips into the medulla of the kidney, so like the core of the kidney, which is this really salty area, and then back up into the distal convoluted tubule, and then it collects in the collecting duct, and eventually comes out as urine, right? So as a filtrate travels through the nephron, there's these different electrolyte concentration gradients that occur, and like there's transporters and channels, etc., that allow electrolytes and fluid and waste to move in and out of the tract. Some things are gotten rid of, others are kept and recycled back into the blood. And to be fair, this is a woefully simplified version of this process. If you're interested, you should, and you should be because kidneys are pretty cool. Go watch some of our videos on the renal system and whatnot, or look things up on YouTube and all of that, because this case does not do the kidney justice at all. So now different diuretics work on different areas of the nephron and affect different things. Different So here's your different diuretics. So you have carbonic anhydrase inhibitors, osmotic diuretics, loop diuretics, thiazide diuretics, and then potassium sparing diuretics. So carbonic anhydrase inhibitors work on the proximal convoluted tubule. Osmotic diuretics work on the distal portion of the proximal convoluted tubule, but then also the descending limb of the loop of Henle. Loop diuretics, like furosemide, we commonly carry that. Work on the ascending limb of the loop of Henle. Potassium sparing diuretics work on the collecting duct. And then finally, most importantly for today, your thiazides work on the distal convoluted tubule. And specifically, thiazides work via disruption of potassium chloride cotransporters in the distal convoluted tubule. And this leads to an increased sodium in the filtrate. So sodium doesn't get kicked out of the nephron, it stays in more and it stays in the filtrate. And then water follows sodium, right? Water follows salt. So it leads to a decreased total body water, and thus it can help hypertension and edema in that way. It keeps sodium there, water follows sodium, so it keeps more water to get rid of. And again, an oversimplification, but you get the point. The jam with that, and the jam with thiazide diuretics and most diuretics, is you get this surge of sodium that then travels back down into the collecting duct. And then in the collecting duct, there's lots of sodium potassium transporters that steal some of the sodium back at the last minute. And to do that, it has to trade potassium for it. So we waste a lot more potassium in the end because there's this big chunk of sodium going down. Hopefully that makes sense. Basically, thiazides shut down sodium chloride cotransporters in the distal convoluted tubule, which leads to more sodium staying in the filtrate, which is good because water follows it, but it leads to more being available to trade for potassium later as a side effect. And that's most of the reason why John is in his current predicament. So, what did we do for this guy? And to be honest, really not much, right? This is more of a cool look at I found diagnosis and less of a let's treat this pre-hospitally diagnosis. So we thought about giving MAG, however, it was ultimately deferred because it was totally not within our scope of practice at the time. And calling medical control would have ultimately just wasted time. We were less than like 3 to 5 minutes away from the hospital. But because we caught it and because we called it in a very specific way, John saw a doctor within minutes and got a bed in an acute area of the hospital immediately with iStat labs at the bedside confirming what we had assumed. He's got a critically low potassium. So his potassium was only 1.7. His mag was also low at 1.2 or no, 1. And for treatment, he got his potassium and mag repleted. He was admitted for a few days. He was taken off hydrochlorothiazide. Ended up being placed on amlodipine instead, I believe. All in all, it was an interesting case and a cool to kind of be able to clinically suspect the right disorder in the field. I hope some of you were able to catch that too. If anything, this is why understanding pharmacology and knowing kind of 10% more than the textbook states makes a big difference. So with that, thank you for watching, and I will see you next time.